So, welcome everybody to the first of our Women's Health Midweek Matters this month. We are so honoured to have joining us Moneli Golara, an extremely highly qualified gynecologist who works both in the NHS and private. And I'm just going to read a little bit from your one of your website, Moneli, because I think it really sums up the philosophy that you work with. And she believes that every woman is unique in her needs and treat them according to their individual circumstances. She believes that firmly that every patient should be treated the way she would expect to be treated herself, being female and a mother of 2 adult children, including a daughter. She's fully aware and understands the impact that gynecological conditions can have on the physical and mental well-being of women. And we have invited Moneli, this evening to explore women's health when you have a physical disability, obviously specifically for cerebral palsy, but I think a lot of what will be covered and some of the questions will be apt for many physical disabilities as well. So Moneli, welcome.
Thank you very much.
And thank you for joining us.
Thank you, and I'm honoured to be invited by Emma and Miriam to this forum, obviously we're going to keep it as informal as possible, as patient-centred as we can, we're going to basically cover relevant women's health problems. Now, we are unique, we are complicated, there are a lot of aspects to women's health. There isn't just one topic that we can cover in 60 minutes. There's a lot of different interacting situations that periods lead to mental health, lead to side effects, lead to hormone problems, and so as we said earlier, that every woman is unique and individual. However, it is important to have a bit of an understanding of the female reproductive organs, of the female reproductive tract. I am not aware of specific research being done in cases with CP. However, from my understanding, and correct me if I'm wrong, cerebral palsy is a very broad condition. Not any two women are the same. Not any two patients are the same, and that is the beauty of medicine, in that if you can tailor every treatment to that individual, you don't have to have a broad all-fitting, all-dancing treatment to gynecological conditions. So I'm aware that some of you may not have much medical background. Some of you may do, but we're going to keep the talk very broad and very basic, and hopefully simple to understand. And if in the meantime you have any questions, please obviously either put it in the chat or button, and we'll be happy to just have a generalized forum. So I'm going to share my screen. And that's it. I hope you can see that. Right. So we're going to just do a bit of an update on women's health, and we're going to start with the basics. So this is what we all remember and what we all know: female genital tract. Externally, the vagina, the cervix is at the top of the vagina. You then have the uterus, which is often tilted in a lot of women. And then you have your tubes and ovaries within the pelvis. So a lot can happen. It serves a very important purpose, ultimately of reproduction, but it's not used in every woman for reproduction. It's important to understand the anatomy and physiology so you can understand what happens when things don't quite go right. So the next slide is a little bit complicated, but I'll try and explain it. This is what happens at puberty. So if you look at the bottom here, oh, sorry, I don't know why this is moving, but if you look at the bottom here, this axis at the bottom, this is the age of the young girl, and it starts from the age of 8. Around the age of 9.5, women or young girls start developing breasts. That goes on between age 9.5 and 10.5. Around the age of 12 to 13, they start having their first period, and puberty is completed around about age 14.5. And this line in the middle is how fast they grow in height. So they grow in height the tallest just before hitting puberty. And once you've hit puberty, you don't grow up in height as much as you did. And I'm well aware of the complications that cerebral palsy has on bones and on the length of bones and then the consistency of bones in some cases. However, the sequence of puberty is probably the same, and bone growth and epiphyseal bone plates that cause the growth of bones, I don't think, as far as I've read, has been any different in women with CP, but things may come out to prove us wrong. Now, this one is also a bit of a busy slide, and I'll try and explain to you exactly what this is. This is the menstrual cycle. So the menstrual cycle, at the bottom here, if you can see, is the days of the month. And a cycle is 28 days. You all know that. Periods, you think normal should be 28 days. However, anything between 25 and 42 days is considered normal. But the cycle runs on a 28-day basis. At the top is what happens in the ovary. So you start with a little follicle. As you go along, the follicle grows. Mid-cycle, the follicle is released, and then that follicle becomes a little solid piece of material. What happens in the second row is your body temperature, and your body temperature can rise around the time of ovulation. So some people might feel hot flushes. In mid-cycle, you might feel that your body temperature is changing. You might feel that you feel hotter or colder, and you might get it's normal to have some temperature changes in your body in the menstrual cycle, as you can see. Under the body temperature, we have the brain hormones. These are the hormones that peak and cause ovulation. These are the two hormones that come from the brain called FSH and LH. And these are the blood tests that your doctor would measure if they want to see if things are good, if things are going in the right direction. These are the hormones that we measure if we're worried if people are going through the menopause. And these are the best hormones to measure because they are steady and they don't fluctuate that much in the cycle, except at mid-cycle. And if you are going to measure them, best time to do it is when the woman is on a period. So if you go to your doctors and say you want some blood tests to see if you're reaching menopause, if your doctor knows what they're doing, the blood test should be done when you're on that period, not any other time of the month. Certainly, if you check the blood test when people are ovulating, then it will be very raised, and sometimes it can be misdiagnosed as menopause. So you've got to make sure that the blood tests are done at the right part of the cycle. You then have the two very important female hormones, estrogen and progesterone. And I'm sure you all know what they are. So these hormones work sometimes together and sometimes against each other. But what happens before ovulation is you have very high estrogen levels and then they suddenly drop at the time of ovulation to allow progesterone to rise. And that drop in estrogen can in some women also give them hot flushes and night sweats, and they might also feel some menopause symptoms in the mid-cycle because you get that sudden drop in estrogen levels. And then the important part of it is the second half of the cycle, because you have these two hormones, estrogen and progesterone, in the second half of the cycle after you've ovulated, and the fluctuations of those hormones against each other can cause some effects on women, traditionally what we call premenstrual syndrome. And premenstrual syndrome is a difficult one because it's not the increase or deficiency of one hormone. You could measure your hormones and they could be completely normal. What happens is the fluctuation of those hormones that can have this effect on mental health. It can have your effect on fatigue. It can have an effect on energy levels, on your appetite. Some women get migraines in that part of the cycle. Some women who are prone to epilepsy may notice more epileptic seizures in the second half of the cycle. And that is because of the complex reaction of the two hormones of estrogen and progesterone together. And finally, the bottom one is what happens in the womb as a result of all of this going on. The lining of the womb in the first 5 days is when you're on your period, you're shedding the lining of the womb. It then starts growing, and towards the second half of the cycle, you develop the lining of the womb, that juicy layer that if a pregnancy were to happen, that's where the pregnancy would then embed, and that's where the placenta will develop, and that's where the baby will continue to grow. These blood vessels that you can see in the lining of the womb are responsible for the growth of the the placenta if a pregnancy did happen. And that is why if a pregnancy doesn't happen, when you release all that tissue, there is some bleeding associated with it. That is why we get periods, because the lining of the womb that we have developed has a full blood supply in order to develop a placenta for a pregnancy. And that is all very relevant in what happens. And the reason I put this slide is to show you two things. Firstly, if you ovulate a mid-cycle, you have a period. And secondly, if you have a period, it means you've ovulated. So ovulation equals menstruation, menstruation equals ovulation. So in some women who get erratic bleed cycles, in some women whose periods are irregular, and in some women whose periods have stopped, it's because ovulation hasn't happened. And the reason sometimes ovulation doesn't happen in some cases, very specifically, significantly to women who have other conditions such as CP, is medication. Because some of the medication that we give to women to control seizures, some of the medication that people have to control epilepsy, tone, etc., can affect the FSH and LH levels in the brain, and that can inhibit ovulation. And it is very common, therefore, to see that some medications affect periods. Doesn't mean there's anything wrong with you, doesn't mean you don't have the eggs, it doesn't mean that there's something sinister going on. It just means that there's an interaction with some of the medication that you may be on that has affected your ovulation, and by not ovulating or by ovulating late, your cycles might become erratic. And of course, erratic cycles can be a cause of anxiety for a lot of patients, because you think the normal is to have a once a monthly bleed, but as long as that erratic period has not affected the lining of the womb, which is this last layer at the bottom, and as long as the lining of the womb is not getting too thick, there is no harm to you from erratic cycles. Yes, we'd all like to have normal periods. Yes, we'd all like to feel that we're on a cycle. Some of that is the perception that we have of having what normal should be, and some of it is to do with what others tell us what normal should be. But the reality of it is that erratic periods are not harmful as long as you have at least 9 periods a year. So keeping a track of periods is important. But I wouldn't get too stressed if you are missing periods and you haven't had one for 42 days or 41 days or 43 days, which may be because some of the medication you're on or some of the other conditions that you might be suffering from. So I hope that's been clear. So now that we understand what the normal physiology, what happens in our bodies and what triggers what, we're going to talk a little bit. So I tried to divide the talk into the different stages of a woman's life. And obviously an important stage of any woman's life, if they choose or if they want to, or if in that situation, would be pregnancy and their reproductive life. But I haven't got enough time to go through every single aspect of pregnancy and antenatal care in this 1 hour. So we're going to keep this talk mainly towards gynecology issues and what can happen from a gynecological point of view, and I've divided it, tried to divide it into the different stages that we go through in life. Although the stages are all interactive with each other, it's never a stop-start situation in any woman's life. But we're going to start with menstrual life. So you've grown through puberty, you've put the childhood behind, you've started your periods, which hopefully by the age of 16, in most women, you have started periods. I have patients sometimes who come at 17 and they still haven't started their periods, and we do some tests, but generally the majority of women would have started their periods at the age of 16. So what can happen when you have your periods? Okay. I don't know if that's a question. If there's any questions, let me know. But what can happen when people have periods? And the most common symptom people complain about is abnormal bleeding. And abnormal bleeding can be quite distressing. And what we normally know from abnormal bleeding...
Moneli, sorry, I think we just need to get the other person on microphone muted.
Okay.
Bear with me. I think there you go.
Okay. Sorry.
Yeah, fantastic. Thank you.
Please, if you have any questions, butt in. I'm happy to stop the talk and go back. But abnormal bleeding, often people worry that there's something really nasty going on, or do I have cancer, or could it be because of cancer? And the reason I put this slide is to actually show you that only 10% of women who have abnormal bleeding may end up having pre-cancer or cancer. And in about a good half, there's nothing going on. It's a normal cavity, and they may have nothing else going on other than a bit of hormonal imbalance, a bit of background like we described, and that's why they're getting abnormal bleeding. But of course, some women may have fibroids, and I'll tell you a little bit what fibroids are. Some women may have polyps, very similar to fibroids. These are lesions that grow inside the uterus, and they can cause abnormal bleeding. And it's very common. In a population of between women aged 30 and 50, about 20% will describe some sort of abnormal bleeding. And I'm sure there's many of you in the audience who at one point in your life have noticed that you've got some degree of abnormal bleeding. So what the main distressing thing about periods in a big group of women is heavy periods. And heavy periods in medical terms is what we call menorrhagia. But I don't expect you to know that word or remember that word, but your GP may put it in a letter. They may put it in a scan request or something like that. And menorrhagia is just a Greek word to mean very heavy periods. And it's excessive bleeding and it's excessive periods, but it's a tricky one because there's no way we can measure to say, okay, if you have 1 cupful, it's a normal period, but if you have 2 cupfuls, it's a heavy period, because it's very subjective to that individual. So what might be a light period for me, for somebody else, might be a very heavy period. And it's difficult to say, oh, you don't have heavy periods, because if you perceive that your periods are heavy, then they're heavy. If the periods are interfering with your self-care, if you're finding it difficult to control with pads and tampons and hygiene products, if you're leaking through onto a wheelchair, to you, that's heavy periods. It doesn't matter what anybody else says. It's a perception of your periods and the way it interacts with your life. And if you look at the definition, is the period if it interferes with a woman's physical, emotional, social, and material quality of life. You are the only person who can make that decision. Nobody can make that diagnosis for you. I have patients who come and see me who say, oh, we went to our doctor and they said, no, your periods are not too heavy. Don't worry about it. But nobody else can say that. It's the patient themselves, if they are suffering, however heavy or light they may seem, if the period is interfering with your physical, emotional, social, and material quality of life, that is something that we need to deal with. So doctors sometimes, and I'm guilty sometimes myself, we can be a bit dismissive. And as I said, every woman is individual. If you feel that your periods are bad, you need to seek help. And that's the end of it. There's no definition for menorrhagia. So if you take women off the street and ask them, are your periods bad? About 1 in 3 will say yes. And that's a big chunk of a female population. Now, what we all understand is women are carers, women are mothers, women, some women work, we're a big part of society, and no woman should feel that the periods are affecting their roles in their lives. So I think it's very important to be clear that if you are suffering, then you need help, and not be put off by some dismissive attitudes that, oh, well, you're a woman anyway, and periods, everyone gets periods, so don't worry about it, and just just use heavy pads. So about 1 in 20 women would consult their GP each year, but 1 in 3 would complain that their periods are heavy. That just goes to show that a lot of women would feel either embarrassed to go to their GP, they would feel they'd be fobbed off, they would feel that perhaps the GP may not take them seriously, they would have not time to go to the GP, they may have access to healthcare, like somebody who perhaps has cerebral palsy, and they may not be able to go to their GP to complain about periods because they've got other issues that take priority. So it is a problem in terms of access, and it is a problem in terms of perceptions of what should be normal and what should be accessible. However, of those women who go to their GP, in the majority, nothing abnormal is wrong with them. They just have heavy periods, and some cases they have other things going on. Sometimes it's due to some medication that they may be under, and the thing that we're finding more and more is that patients are given blood thinners for whatever reason. They're on tablets like aspirin, apixaban, edoxaban, clopidogrel. You might be taking some of these medication. If you have immobility and your GP or your neurologist has suggested you might need to take blood thinners, and we know that blood thinners cause more bleeding. They may have a condition that affects their thyroid. They may have an underactive thyroid. They may have liver or kidney disease. And these are all conditions that can affect periods. So if you feel your periods are heavy or they're bad, please do seek help, because there may be something causing it. And if we can treat that cause, then already your period might become a little bit better. Okay, so how do we treat heavy periods? There's an array of medication that you could have. What we would firstly do is we would look to see if there's a cause. So we would arrange for the patient or for you to have some blood tests to rule out other conditions. We would then arrange for you to have an ultrasound scan of your pelvis. I have seen 2 patients with CP who needed an ultrasound scan of their pelvis. And if the team in the department are aware, they can provide access and help for the patient to have an ultrasound scan. Some of the scans have to be internal scans. Again, if we're aware that there are issues, we can make it more comfortable and more accessible. But what you need is an internal ultrasound scan to see if there's any reason why patients are getting heavy periods. And the way we treat it initially is with some tablets, and the main one is called tranexamic acid, and that is a tablet that's non-hormonal, and it is a tablet that reduces the flow of blood, and it's very, very helpful because you take it on a heavy day, and on those heavy days, so say your periods are heavy for only 1 or 2 days, and you're not keen on taking any other medication, so we give you some tablets that you take on the heavy day, and it reduces the flow of blood. And it's very useful, and some of you may have been given a prescription. But ultimately, the best way to treat heavy periods is to hormonally manipulate them. Now, if you remember the slide I showed you first, that ovulation equals menstruation, sometimes by stopping ovulation artificially, periods stop. And the best way to do that is in the aid of hormones, such as the pill, the mini pill, or the hormonal coil. And the hormonal coil has been revolutionary because trying to remember to take a pill every day, or if you have a tummy upset, or if you're taking other medications such as anti-epilepsy medication and you can't take a pill every day, or if the pill is giving you side effects, it's very, very easy for us to put a coil inside the uterus that releases the hormone inside the uterus. And it has been revolutionary because women who have a hormonal coil stop having periods. And by stopping the periods or making them a lot lighter, you can actually transform somebody's life completely. And the coil is very useful because it stays in for 5 years. Before the coil was introduced, before it was invented, a lot of women would end up needing a hysterectomy because their periods were very bad. But the number of patients needing a hysterectomy since the invention and the use of this coil has gone right down. Emma's got her hands up. Did you want to ask something, Emma? No? No, maybe that's a mistake. Okay.
Actually,
I wanted to just...
Oh, yeah, go on then, Emma.
I just wanted to ask on behalf of somebody here.
Yeah.
Although it sounds like a really good idea to have a coil fitted,
yeah.
If you already know through your experiences of having smears and things like that, that having the coil actually fitted is going to be problematic in terms of spasm or
yeah.
those kind of things. Is there a way in which that can be is there ways that you can problem solve that? I guess is the question.
There is. We have, although we put coils in women when they're awake and when they come into the clinic, I feel that in some women that is not appropriate. I have put in coils in very young girls with disabilities and in one patient with CP, and I think it's much kinder and much more gentle to do it under general anesthetic if possible. It may not be possible, but if not, then I think one thing we can try and do is either to use some sort of analgesic that's also a muscle relaxant, or maybe with the use of some Entonox gas and air. So I don't know if we've had any experience with that, but we are, there are ways that you can go around it. However, if somebody comes to me with very heavy periods and they need a coil, and the coil putting it in under local when they're awake is not possible, then we have had many patients who we bring in and do it with some a bit of intravenous sedation, a bit of gas and air, and a bit of painkillers, or under general anesthetic. I know it sounds drastic, and I know it sounds probably a very big step, but it does transform people's lives. So, for example, I had a young 13-year-old girl who had started having her periods. She had disabilities in the I don't think she has cerebral palsy, but she had a severe epilepsy. She couldn't swallow tablets, and she was flooding everywhere, and it was very distressing for her and for her carers. And we brought her in, gave her a quick 5-minute anesthetic, put a coil in, and the coil's been there now for 4 or 5 years. It stopped her periods and it's transformed her life. So there are ways of working around it, and every person is individual. So it's very difficult to say one size fits all. Has that answered your question?
I think you have covered it. Thank you very much.
Okay, you're very welcome. So let's go. There's another hand up here, Sarah. Sarah Finlayson, did you have a question?
Yeah, I used to have heavy periods for about 3 days, and then my periods would stop.
Yes.
After the second day, it started to like dilute. And then on the 3rd and 4th, it stopped altogether. So I had very short periods, but they were really heavy.
Sure.
And my solution was, because it was really problematic, keep changing me, and because I can't do it myself,
of course,
at the time, so I used Cerazette,
yes,
which was a pill, but I took the pill all the time.
Yes.
So I didn't take I didn't like do it and then stop it and then start it. I took it for about 20 odd years. Anyway, now I'm menopausal. I don't seem to have that problem anymore.
Yes, well, that's a good point, and thank you for bringing that up, because Cerazette is actually progesterone that you can take by mouth. So if you remember, I said that you can take hormones, estrogen and progesterone, or progesterone, and you can take tablets by mouth. Cerazette is the progesterone only pill. It's the mini pill. It's a very good way of stopping periods. You take it every day. You don't give a break. And in the majority of women, it stops periods. It's a contraceptive, and if you are happy taking a tablet, then that's absolutely acceptable and it's the right thing to do. It's just that some women prefer not to have to take another tablet every day, and sometimes in those situations a coil can be helpful. But again, as I said before, it's not one glove fits all. Every woman is individual, and it's after discussion with them what they would prefer and what they would like. It's just, in our experience, the Mirena coil is really effective in stopping periods without the need for taking tablets and stuff every day. But yes, the Cerazette is absolutely fine to do. Okay, who's got their hands up? I think Miriam.
Yeah. I was just wanting to ask you. I'll just lower my hand then. So you explored the idea of having a light anaesthetic regarding putting in a coil.
Yes.
If I can just explore the smear question that somebody has explored with us, is if if there is a problem having your the GP having your smear done at your GP practice for whatever different reason,
Yeah.
is it possible to be referred to your local gynecological clinic at the hospital?
Absolutely. I don't see why we get referrals from GPs all the time where patients have not been able to have a smear test for whatever reason, or the nurse hasn't been able to find the cervix, or for whatever reason. And we do smear tests. I'm going to talk about smear tests towards the end as well.
Oh, okay,
I'm going to
that's
have a
fine.
little slide about that, because doing smear tests is actually very, very simple. You know, women often think that they have to go in a certain position and be on their back and you know, open their legs. You can actually do a smear when the patient is lying on their side. So I'm going to talk about smear tests a little bit towards the end of the talk, and we'll come to that. So
Can I ask one other question about
course.
the progesterone
Yeah.
only? Is there a long-term consequence of not having a period?
Not at all, because if you remember from the slides, what happens is you build the lining of the womb and you shed it. When you're on progesterone, you don't build it. So there's no reason, the reason you're not having a period, it's not that it's all building up inside and not coming out. It's because that lining that you build up, you don't. Progesterone keeps that lining thin, and therefore you don't build up the lining of the uterus, and therefore you don't have anything to shed.
Thank you.
Okay. So moving on, if you have a scan, you might find in some cases that you have these things called fibroids, and fibroids are very common, actually. If you look at women between ages 35 and 39, 40% of women have them, and they sound a bit scary. They sound like these lumps, but actually they're just benign lumps of tissue. I've put some pictures here. I hope we don't have anybody too squeamish in the audience. I try to keep them as sort of simple as possible. But if you look at the slide at the top, there are these little lumps that grow on the uterus. They grow on the womb, and they can cause abnormal bleeding, and they can cause heavy periods. And sometimes they can get really big. They can grow to about 9 or 10 centimeters and cause pressure symptoms. But regardless of how big they are and where they are harmless. They are not cancerous. They're just benign lumps. So we treat fibroids according to what symptoms it's giving us. And in some women, if the fibroid, like you see up here, is in the cavity, it's very easy to deal with because you put a camera inside the cavity, like you can see these pictures, and the fibroid can be removed from inside the cavity. If the fibroid is somewhere else, then some people need a bigger operation, and we would only do that bigger operation if we think it was needed, because fibroids are harmless. They don't cause anything nasty. They just cause pressure symptoms and heavy periods. And if we can manage the heavy periods with the help of the hormones, then surgery is really not needed in the majority of patients. I have patients who come and see me. They say, a GP did a scan, I have fibroids, please, can you remove them? And I look at it and say, you know what, the operation to remove the fibroid is much harder than the fibroid itself. So we decide to basically manage fibroids conservatively. So that's what we would say about fibroids, but they're very, very common. So don't be alarmed if your GP organizes for you to have a scan and it says you've got 1 or 2 fibroids. Any fibroid less than 5 centimeters, which is quite big actually, we would ignore. We would say this is normal, don't worry about it. And then there's this condition called endometriosis. Now, I think there was a few questions where Miriam sent me. I think there was 1 or 2 about endometriosis, and I thought I better put 1 or 2 slides. Now, endometriosis is a benign condition. It's not nasty. It's not cancerous, but it sounds, the word itself sounds a bit scary. So the lining of the womb is called endometrium, and endometriosis is when the lining of the womb finds itself outside. So imagine the womb is like a room. The lining should be the paint stripping of that room. When the lining finds itself on the outside of the room into the pelvis, that's a condition called endometriosis. And if you did an operation and you looked inside the pelvis, this is what it looks like. You get these little dark spots. The problem with endometriosis, it can cause pelvic pain. Now, there was a question as to whether it's more common in women with CP. I've tried to scour the literature. I can't see any evidence anywhere that women with CP are at greater risk of having endometriosis. However, it is very common. It's in 10% of females. That's already 1 in 10 women. It causes pelvic pain and heavy periods. And the risk factors are if you've not had a pregnancy, so women who don't have children, If you've got a low BMI, I know BMI is not something we normally talk about when we talk about CP, because it doesn't necessarily apply to cerebral palsy, but there are some correlation in women who have less body mass, who have earlier periods, and who have a later menopause. So then the more periods you have in your life, the more likely you are to get endometriosis. And the things that protect against endometriosis, so if you had a mother, sister, or a daughter with endometriosis, that gives you one of the risk factors. If your period started very early, if you have lots of cycles in a month, so in a year, so say if you have more than 12 cycles in a year, if your periods are heavy, or if you had difficulty conceiving. But what prevents endometriosis in women is pregnancy, later starting of periods, breastfeeding, and we know that healthy diet, there was some studies that suggest a very healthy diet with more fruit and citrus fruits could have a protective effect. There was also one study that suggested eating red meat could have a negative effect. So these are all factors that can affect women, but they are very broad. So, 1 in 10 women will have endometriosis. And whether it's more common in women with CP, I couldn't find any evidence. Maybe we could start looking at that to see in a population, is it more common or not? Something to think about. Again, the treatment for endometriosis is hormonal, and the best treatment is progesterone. Again, like Cerazette, like Sarah mentioned earlier, that is progesterone. Progesterone calms down these spots, and the best way of giving progesterone is with a coil. And for those of you who don't know where it goes or what it looks like, it's a little small device, and it goes inside the uterus, and it releases this progesterone into the uterus, which then seeps out, and it helps with pelvic pain. So women who have endometriosis or heavy periods, the treatment of putting a coil inside reduces blood loss, reduces pelvic pain. It's a contraceptive if you've felt you needed contraception. It reduces PMS because it inhibits the ovulation. Remember, ovulation equals menstruation. By inhibiting ovulation, you don't get the PMS. And in 80% of women, they become amenorrheic. Amenorrheic means you don't get periods. So it's something that you might want to consider, and we can talk later. So we've talked about puberty. We've talked about why women get periods. We've talked about heavy periods and things that can happen in midlife. We haven't really talked about reproduction and antenatal care and pregnancy. That's a huge talk, and another talk on its own. I'm happy to come back at another time and maybe talk about antenatal care and pregnancy and things that can happen and things that can go wrong. But we're going to move to menopause because we're living longer. We're all living longer. We're having more help, we're having more treatment, and we're all living longer. So it will come a stage where we're all going to be active, we're going to be healthy, but we're going to be in our 50s and 60s, and we're going to suffer with menopause. Now, we do know that menopause symptoms can exacerbate certain neurological conditions. Again, I couldn't find anything about CP, but certainly epilepsy. If you suffer with epilepsy, it can get triggered with menopause symptoms. Again, the lack of estrogen. One of the symptoms of menopause is fatigue, and I know that's a big symptom in some of you who suffer with CP. So it's important to understand the changes that body goes through, both for you and your carers, when you go through the menopause. Now, what does menopause mean? Menopause means that your ovaries have stopped producing eggs. So you are born with about 1 million eggs. And as you go through your life, remember those follicles that I showed you, by the time you're 50, you run out of these eggs and the ovaries stop working. And when the ovaries stop working, you start becoming low in estrogen, and low estrogen levels can give you hot flushes and night sweats. That's the most common symptom. And if you're somebody who has poor sleep anyway, because of your tone, your pain, your sleep is disrupted, and you then have to wake up 10 times a night because you're having hot flushes, that will only compound your well-being the next day. Women can also get vaginal dryness and urinary problems. Some women may have background history of urinary problems. And then if you add menopause to that, the lack of estrogen on the bladder can cause irritability. You can get leakage, and you can get frequency and a very irritable bladder. People can get joint pain. Well, I'm very well aware that CP can also cause joint pain. So these are the things that can actually compound your symptoms. It is becoming more and more of a problem, and I'm sure you've heard and you've read on blogs and podcasts and celebrities coming on television talking more and more about menopause, because it used to be a taboo subject. Your mothers and grandmothers would call it the change. They wouldn't even say the word menopause. They say, oh, I'm going through the change. It was a secret code. But we're now talking more and more about it, because we're now playing more important roles in our society, and we need to be able to tell people what our symptoms are so that we can talk about it and help each other. So the menopause transition is a gradual transition. It starts around about the age of 45. And that's when your periods are stopped becoming so regular. You might not ovulate every month, and it's a gradual transition where you get more gaps in your periods. And like Sarah said, eventually the periods stop, and she came off her Cerazette because she didn't need it anymore. And your periods will stop. And if you wanted to see if you're going through the menopause, your GP, remember those blood tests that I mentioned to you, would do your FSH and LH levels. But the idea is that one level is not enough. You need to have 2 blood tests 6 weeks apart. However, blood test doesn't matter. It doesn't matter what the blood test says, because we treat the individual, not the blood test. So your GP will not turn around and say, actually, Miriam, your blood tests are normal, so go home and put up with your symptoms, because blood tests shouldn't matter. The fact is, the woman is 45 and above, is having erratic periods and cannot sleep. Whatever the blood test suggests, we still should be able to help you. So the perimenopause lasts about 4 or 5 years, and it's a gradual change. We're not an on-off switch in our body. You don't have 1 minute you're on and 1 minute you're off. It's a gradual change, and that's what's known as the perimenopause. You could still be getting all the symptoms. You can have the hot flushes, night sweats, vaginal dryness. Your blood test may be normal. You might still be getting your periods, but you are suffering. And one of the main things is vaginal dryness. And vaginal dryness is very easily treated, because there are now some pessaries which contain estrogen, which you can buy over the counter, and it's called Gina. And you don't even need to get a prescription from your doctor. You don't need to go on a Zoom meeting or a consultation. You can just go to Boots, and if you're above 50 and you have vaginal dryness, you can get these pessaries. And you need to be able to insert it into the vagina. I'm aware that sometimes it might be difficult inserting tampons and pessaries and stuff like that in. You can also get a cream for estrogen, which will also help with vaginal dryness. And the reason I put vaginal dryness high up is because we don't realize that vaginal dryness can affect our bladder function. So if you already have issues with your bladder function and you add to that the vaginal dryness, that can make your bladder function worse. So if you notice that this is happening, don't suffer. Get some vaginal estrogen. It is completely safe. You can either use it as a cream or a pessary. It's not HRT. It's not going to give you a breast cancer. It's not going to cause you any other illness, because it's only working in the vagina where it should. And it should help you with the dryness if you're experiencing in terms of bladder function. Now, obviously, you can either have these pessaries, you put it inside the vagina, it helps with the thinning, dryness, pain on sex, and some women get bleeding from soreness. You can either have it as a ring, so this may be useful because you put a ring in the vagina and you leave the ring there for 3 months. So you don't have to keep putting things in and out if you find it difficult. You can ask your carer or your GP or the nurse to put a ring inside. The ring releases estrogen, and it helps with vaginal dryness. And you won't need to suffer with bladder issues because it's very, very helpful. If somebody couldn't have estrogen, and the only people who can't have estrogen properly is women who've had breast cancer themselves, then you can have these other products, which are vaginal moisturizers. One is called Replens and one is called Silk, and they do help with vaginal dryness, but they're not going to help with your bladder. So if anyone's having any of these symptoms, please speak out, please talk about it. Please mention to your doctor, please say that you know there's treatment that you can have, and seek the treatment. So, moving on about HRT, if you feel that your menopause symptoms are affecting your life such that you can't sleep, then the solution would be to give you HRT. HRT is very helpful. It's very safe. However, women, patients, people, mothers always worry about the risk of breast cancer. And the risk of breast cancer in HRT has been proven to be very low. And if you look at this infographic that I've got in front on the slides, if you look at the top blue ladies, these are 23 women who would get breast cancer in 1,000. So if you take 1,000 women, 23 of them would get breast cancer anyway, because that's the incidence of breast cancer in our society. If you give them HRT for 5 years, there'll be only 4 extra cases of breast cancer. So some women might look at that number and say, okay, 4 extra cases per 1,000 women of breast cancer, that is not a big risk, and I'm suffering so much that I can't sleep, and my relationships are being affected, and I'm moody and irritable and angry, and I'm suffering severely. I'm willing to take that risk, but that risk is only after 5 years of use. So for the first 5 years, there is no added risk. So that makes it easier to understand. Incidentally, the risk is the same if you take the pill for more than 10 years, and the risk of breast cancer if you smoke or drink or overweight is much higher than if you just took HRT. So what I would say about HRT is, if you feel you need HRT, if you feel it might help you, you can try it for 3 to 4 months. 3 to 4 months is not going to increase your risk of anything. It will just be a useful experiment to see if in any way it will help with fatigue, if it would help with joint pain, and if it will help with the other symptoms that you might be experiencing. Emma, please ask your question.
Okay, I'm just going to put it out there because everybody's heard my story lots, but I just wanted to ask you, have you so in my case, my joint pain got worse, particularly my upper body, which I hadn't had problems with before.
Sure.
And that was normal in comparison to a lot of my friends.
Sure.
But what was different for me was, because of the CP, the increased pain then increased to spasm cycle, and actually it was the spasms that were more painful than the shoulder pain, if that makes any sense. So there was an interrelationship.
Okay. Did you take anything?
So I have started to take HRT, having been through steroid injections, physiotherapy and various other things. So I guess I just wanted to explore or raise kind of this diagnostic overshadowing, to use a fancy term, of people presuming everything's down to cerebral palsy, and yet there is something else going on that may then mean that I might present slightly differently to somebody else, but actually the underlying cause isn't CP.
Absolutely. And that's why it's so important to understand what changes can happen around the perimenopause and menopause. And that is why I brought HRT up, because what you could do and what you did is try HRT and see if it will help in any way, and not be afraid of it, because there is this misconception that HRT can cause cancer. But the risk of cancer is after 5 years of use, and is very small. So if in any way it can help with your joint pain and make your life a bit easier and give you a bit more quality of life, then I think it's worth trying. So I don't think it's going to be any harm if you feel that the changes in your body are manifesting in your symptoms becoming worse, because the only way we can eliminate that is by giving you HRT to see if it makes any difference. There's no test we can do or anything to see if the joint pain is specifically because of CP or HRT or menopause, if you see what I mean. So I think it's very fair what you've done, and I'm hoping that it will help to a degree.
So I guess my question is, I'm quite a good advocate for myself doing the job that I do.
Sure.
And so I was able to go and have quite a robust conversation with my GP, who was quite reluctant. And I just guess I'm asking you, what's your experience of GPs and their willingness to go down that kind of trial and error route with somebody? And how do we not get fobbed off with, well, it's your CP, or everybody goes through this when they get older kind of phenomenon?
Yeah. Okay. Well, if it's any consolation, Emma, it's not just patients with CP.
No.
I have hundreds of patients who go to their GP. They, as soon as they mention menopause, it's like, oh well, you know, it's normal. It happens to everyone. Just put up with it. Take some sage or whatever. And people get fobbed up all the time with menopause, even without suffering with underlying conditions such as CP. So I don't think you're alone. I do think that the current movement for understanding menopause, for talking about it, for publications and books and blogs and social media has been a big momentum. I now get invited. Some of these slides that I'm presenting now are what I give to GPs. I get invited to GP practices. The British Menopause Society is very vocal. If you look on the British Menopause Society website, there's a wealth of information that you can find. And you can challenge. I think you have to just challenge your GPs, and GPs now are, in my experience, they're getting a bit better. Yes, the old school was, oh well, it's just menopause and put up with it, and your mother had the same, and my mother had the same, and it just going. But those responsibilities have changed. Maybe 40 years ago, my mother didn't have any job and just sat home and knitted. I don't know. But our responsibilities in life have changed. We have a lot more going on, and we have a voice. So I think it's important to persevere and seek help. And if you're not getting help from one place, seek it from somewhere else. But in my experience, the GPs are getting better. So don't all be disheartened. Menopause is something that we talk about. But I do think that if you are noticing symptoms, there is no harm in trying it for 3 to 4 months to see if it makes any difference, because anything to make life easier. Has that answered your question?
Thank you.
Okay, right. Okay, so say if you didn't want to take estrogen immediately, or if you didn't take HRT because you were worried because maybe your mom or your sister or somebody you know had breast cancer, or maybe if you had breast cancer yourself, then there are estrogen products in certain food products, and they are called phytoestrogens. Phyto means plant. So certain plants have estrogen in them. And the most important food groups are called isoflavones and lignans. And isoflavones are found in soybeans, chickpeas, red clover, legumes, and beans. And lignans are in flaxseed, cereal, fruit, and cereal bran. So there are certain dietary things you can take. There is red clover, which is a lignan, and it has been shown in one study to reduce hot flushes and night sweats. But I have no data around bone pain, and I have no data around fatigue, and I have no data around anything else, other than women who take these dietary plant stuff get less hot flushes. Of course, with anything dietary, you cannot overdose. Your body will absorb whatever it can, and the rest will come out the other way. So if you take some soybeans, you're not going to overdose on estrogen. So soybeans, whatever you take will absorb, the rest of it comes out the other end. So if somebody said to you, oh no, you can't have HRT, you might want to try some dietary modifications that might help. There are some alternatives to HRT that have been shown to help, such as red clover and black cohosh. But the problem is, if you go to a health food shop, every preparation has a different dose. We don't know who's getting what and how much people are getting, and it's much easier for us to give a prescription with HRT. And of course, there are some antidepressants that help with hot flushes, and sometimes they can also help. But of course, antidepressants have their own problems with addiction. Some people feel weight has gone up, and some people feel their sex drive has gone down. So it's not the first line treatment. We talk very briefly about bones. Obviously, I think you have next week the Osteoporosis Society talk on bones. I'm not going to go on much about bones, but we know that the lack of estrogen causes bone loss. And if you're already vulnerable with your bones because of your immobility, because of your disability, then if you go through the menopause and don't have any estrogen, you can lose bone. And so it is something to consider of the benefits of HRT. And if you have proof that you are losing bone, such as a bone scan or whatever, then we would say you might want to go on HRT to prevent bone loss. So I will leave the rest of the bone talk for next week from the Osteoporosis Society, but please remember bone health is important. Sunshine, vitamin D, calcium intake, and exercise as best as you can within the confines of your disabilities to keep the bones healthy and strong. Calcium is present in some foods. You don't have to eat cheese or milk, or you don't have to necessarily eat tubs and tubs of yogurt. If you look at the calcium content of things like salmon, nuts, tofu, boiled spinach, they have quite a good calcium content. So if you are worried about your bone health, then a lot of foods have good calcium content that in the context of healthy eating, you could help with calcium supplementation. And then there's this thing called sarcopenia, and I'm sure they will talk to you about it next week. Sarcopenia is loss of muscle. And I know that with certain disabilities like CP, the immobility can cause sarcopenia. That's why the role of the physio, the role of the carer is very, very important, to try and do exercises as best as you can with your physio, as best as your abilities, especially upper body exercises if you can, to provide enough stability for the spine. But again, I'm not going to talk about bone loss much because I'm going to leave it for our guest for next week. I'm going to very briefly talk about cancers because smear test comes in the talk about female cancers. Now, remember the female genital tract? Women can get 3 cancers through that. You can get cancer of the cervix, and that is why we do smear tests. The reason we do smear tests in this country is, or in the world, is because cervical cancer is one of the cancers that has a very long pre-cancer stage. And those are the cancers where the pre-cancer stage is very long that you can do screening for. There is no point screening for conditions like ovarian cancer, for example, because there's no pre-cancer stage. Is from 0 to hero very quickly. But cancers that have a long pre-cancer stage, such as cervical cancer, you can do screening. And the screening is done by doing smear tests. Now, in the old days, the smear test would need to take some cells from the cervix so they can look at the cells under the microscope to see if there was any pre-cancer cells in that. And that is why it's called a smear, because they used to smear the cells on a glass slide and look at it under the microscope. But now we don't need to do that because now we know what causes cervical cancer. Cervical cancer is caused by a virus. The virus is called human papillomavirus, or HPV. HPV is very common in couples, but it's the anogenital HPV, i.e. if the virus finds its way into the vagina or into the anus, that can cause changes on the cervix. And that happens mainly after sexual activity and about 10 years after contact with that virus. So if you've never had sexual activity, then the risk of getting cervical cancer is incredibly small. And therefore, you do not necessarily need to worry about having an HPV test. Yes, you can, if you want for your reassurance, or if you're not sure, yes, by all means, do have the HPV test. But what I will tell you is that the risk of cervical cancer is minuscule in women who have never had sexual activity because you have not caught HPV from anywhere. Now, HPV is very common. 10% of women worldwide will have HPV, but not 10% worldwide will have cervical cancer. So only some women with HPV will have cervical cancer, and those are the women who have reduced immunity for whatever reason. So the risk of cervical cancer is higher in women who have multiple sexual partners. And if you look at the famous women who have died of cervical cancer, they are often younger, often have had more sexual partners. It's a disease of the younger woman. If you've been in a stable relationship with the same partner for 10, 15, 20 years and you haven't got HPV, you're not going to suddenly get HPV unless you have a new partner. And the spread is by penetrative sex or very close skin-to-skin contact with the infective area. Now, to check for if somebody has got HPV, you don't need a smear test anymore because the smear was when we smeared it on a slide. What we do now is the PCR test, and we all know what PCR means after COVID. It's the testing for the virus, and it's done on a swab that we then do, like when you used to stick swabs in your nose and in your throat when we used to send it for PCR. It's a very similar thing. We take a sample from the cervix, we put it in a bottle in fluid and send it, and they then look to see if somebody has got HPV in that sample. Now, girls of age of 13 are all getting vaccinated, and so hopefully, zoom forward 20 years, we have got rid of cervical cancer, which will be a miracle. The more cervical cancer we're seeing now in this country is from people who come from abroad, from countries where they don't have the vaccination program. We are now seeing women from Eastern Europe or Ukraine or places like the Middle East where they don't have a vaccination program in place. But zoom 20, 30 years, nobody will be getting cervical cancer. Only 2 of the types of the virus can cause cancer. That's type 16 and 18. There are 100 different types of HPV, but only 2 of them are the nasty ones that can cause cancer. So even if somebody's HPV positive, doesn't mean that they're going to get cervical cancer. Now, to take a sample, you have to take it from the cervix. And to take it from the cervix, as if somebody knows what they're doing, the patient can be signed on the left lateral on their side, and the gynecologist or the doctor can put a speculum in from the side and take a little sample from the top of the vagina, from the cervix. We then send that for a PCR test. If you were found to have the human papillomavirus, normally you'd get rid of it yourself. And that's what women do, because 1 in 10 have the virus, but not everybody gets cancer. There are more than 200 types. It's only a persistent infection that can cause precancer and cancer. So what they do is they take the sample, they check for the HPV, and then if there is HPV, they look at the cells to see if they look precancerous or cancerous. And you might have a sample saying, actually, madam, you're HPV positive, but there's no abnormal cells. Fine. You don't need to panic. All you need to do is have a repeat smear in a year's time to see if your body, with a healthy diet, with a good immunity, you have cleared it yourself. They did a study called the U-Screen study in 2021, where they sent samples to women at home, like when you had your COVID test. And they would send the swab and they would say to women, put the swab into the vagina, put it into the sample and send it over. And they did a big study. And the results of the study came out saying actually 50% of women were happy self-testing for HPV. They didn't want to go to the hospital. They didn't want somebody to stick something up. And they didn't, you know, with the confines of the disabilities that you may find difficult to having smear tests. However, because 36% of women weren't sure what they were doing and were worried, they felt that it wasn't possible for everyone to have that. But women have been doing self-testing of HPV at home. And if you are really worried that you have HPV and it may not picked up and you have difficulty accessing GPs, it may be possible that some of these tests, and I know patients who buy it and do the test at home. It's not something we would recommend. It's not something that the NHS would suggest. But it is possible to screen for HPV without the standard going on the couch, putting your legs up, putting a speculum in, you know, holding patients down and being really traumatic. So that's what I would say we can get through these barriers that are stopping women with disability having smear tests. Sorry, Miriam, you have your hand up.
Yeah, I just wanted to ask a question on behalf of somebody who wrote that she's never had a smear test and the GP told her that because she's a lesbian and never had intercourse, she doesn't need a smear. Is it true, or are they just putting me off because it would be difficult?
Yes, so with women who have sex with same-sex couples, women who have sex with women, if your partner has a HPV carrier and you're in close contact with them from genitally or orally, then they can pass it on to you. So that's not necessarily true that if you're in a same-sex relationship that you don't need a smear test. I would still say that they should have their HPV tested.
Thank you.
Thank you. Okay. So the next cancer is womb cancer. Womb cancer is very easy to pick up. because it mainly presents with abnormal bleeding. And normally women get womb cancer after the menopause. So if anybody has gone through the menopause and has had bleeding, then they need to be scanned and checked for womb cancer. However, progesterone, the pill, and the Mirena coil protect against womb cancer because they keep the lining of the womb very thin. Womb cancer is very rare, but it's getting more prevalent because it's linked to body weight. So for every 5 kilogram increase in the body mass index, there is an increase in womb cancer. And the reason that happens is that womb cancer is caused by excess estrogen, and estrogen is stored and produced in fatty tissue. So if women's weight goes up, so does the risk of womb cancer. It's mainly a disease of postmenopause, but if you have any abnormal bleeding, then it's very important to present to your GP, and they need to look out and see if there's any red flags. And finally, the last cancer I'm going to talk about is ovarian cancer. And the reason I want to talk about ovarian cancer is it's very rare. Is 4% of all new cancer cases, but is very silent. Unfortunately, ovarian cancer does not have symptoms. The main symptoms are bloatedness and heartburn and indigestion. And how many people feel bloated and have heartburn and have indigestion? It doesn't mean you have ovarian cancer, but the time that ovarian cancer presents is very advanced. So do listen to your body. Do not ignore symptoms. If you think that something is new, then obviously get your doctor to check and make sure. Doctors can order a scan and they can order a blood test to rule out ovarian cancer. Okay, I've tried to cover as best as I can all the different stages in a woman's life. I'm sure there's lots that we haven't covered. If there's any specific questions, please do ask. However, I was asked to give 5 tips. I was thinking long and hard about the 5 tips because I think there's more than 5 tips in gynecology. I think there's hundreds of tips. We all need to look after each other. But I suppose stay active as best as you can. Activity is very good for bone health and a healthy heart. Have a healthy diet. Listen to your body. Don't be fobbed off. Report any pelvic pain or abnormal bleeding. If you're called for a smear test, question if you really do need one. If you've never had sexual activity, or if you've had the jab, for example, or if you feel that it's going to be difficult having a smear test, ask, really, do you really need a smear test, or are they just trying to get their numbers up from the GP because the CCG, the funding, won't give them the money unless they do 90% smear tests in the practice. Know your cycle, know your body. Don't panic if your periods are a bit erratic, as I said to you, and don't suffer in silence. We're all here to look after each other as women. Thank you. Emma, you had one last question.
Yeah, I do. And this isn't my question, but it's one that's come through.
Yeah.
And that is that just talking about painkillers and going back to kind of your menstrual cycle and increase in pain and increase in spasm and the difficulty that causes. Is there anything that you would recommend that you know that's a useful thing for somebody to think about?
Yeah, unfortunately, there's been a lot of studies on period pain. And there was a time where we felt that certain painkillers are better than others. And now we have come to the conclusion 100 years later that actually there's no painkiller better than others. Ibuprofen is the best one, standard Nurofen, the best one for pelvic pain. However, if your pelvic pain is due to heavy periods, lightening the periods will do a lot more than painkillers. That is my experience. And lightening the periods is either with, like Sarah said before, like Cerazette, progesterone only pill, tranexamic acid, which will lighten the periods. By treating the problem at source, you will then have to do less firefighting and taking painkillers and hot water bottles and not being able to move and issues like that.
And just to follow up with that question, they also asked, have you seen any relationship between that and neurological changes around the time of periods?
Personally, the only one I have experience with is epilepsy. We know some women suffer with more frequency of seizures around just before their periods, and migraine. Other than that, I have no other experience with neurological issues that can be exacerbated by periods. I'm sure there are. It's just that the studies haven't been done.
Thank you very much.
Thank you.
So I think that at this point, I'd just like to say a very big thank you to you. It's been fascinating. It's such a big topic, and I think what we do know from, the recent information is that research in women's issues and women's health is only really starting to ramp up in the last couple of years.
Yes.
So if you look at the intersectionality of women's health with a physical disability, it's still a little bit behind, but
yes.
I'm sure that
I've always said women's health doesn't matter. I mean, if men had to go, sorry, I don't know if there's any men on these groups, but if men had to give birth, if men had to go through menopause, if men had heavy periods, yeah, years ago, they would have had some fancy treatment for it.
Well, I really also would like to thank you for kicking off the month for us, and for your time and your knowledge. So thank you so much,
You're very
Moneli.
welcome.